Am I audible? Can everybody hear me?
Yes, doc. All good. All good.
All right. So, good morning, everyone. A Sunday well spent brings a week of content. Starting with this beautiful quote, we thank you all for joining us for today's webinar titled Selective FMR. Is that even possible? Our fourth session of the clinical series, Harmony Between Function and Aesthetics, organized by Dental Reach. Dental Reach is a professional site and forum for dentists. It's a place to be visible as a dental practitioner and get appreciated by fellow professionals. Thousands of dentists use Dental Reach to find reliable information on dental education, just like you all are here to put up and see our dental game today. I am Dr. Urvashi, and I will be your host and host for the session while we venture into the fourth part of smile rehabilitation strategies with none other than Dr. Deepa Ravichandran. FMRs are known to break the bank and are one of the most difficult treatments to get converted in clinical practice. But what if I told you that FMRs can be selective and conservative? This is nothing but minimally invasive dentistry at its best. Are you as excited as me to find out what today's session is all about? But before all that, let me put forth this poll in front of you on selective FMRs. And I want you all to answer the poll for me while I introduce to you Dr. Deepa Ravichandran. So, guys, you can see the poll on your screen. Yeah.
Thank you so much for...
One second, ma'am. I hope the poll is visible for all of you. Yeah, and I'll just introduce Dr. Deepa Ravichandran for you. Dr. Deepa Ravichandran is a prosthodontist in Navi Mumbai, where she runs a successful private practice under the helm of Dental Park. She has won awards at both state and national level in her master's program for both paper as well as poster presentations. She has many publications in index journals, Guidant, Famdent, to name a few. Presently, she is the brand ambassador and moderator of Dental Reach, the recipient of the Gomha Awards of 2021 and 2022, recipient of the Doctor's Choice Awards National and City Winner 2021, mentor for the Pulp10 Activa Pronto Challenge, silver winner in the Dental Divas Endo Resto Contest 2021, and a contributing author in How to Conquer Dental School, a one-of-a-kind novel giving young undergraduates a unique perspective in navigating the maze that is dental school. Her forte lies in full mouth rehabilitations, smile designing, and restoring cases of complex occlusion conservative. She has received acknowledgement for the same from peers and patients alike. Over to you, Dr. Deepa, ma'am. Dr. Deepa, are you here with me?
Hear me, Doc?
Dr. Deepa?
Can you hear me?
Yes, we can hear you. So if you could just put up your presentation on the screen.
Yes. So thank you for the wonderful introduction. And I am now going ahead with my presentation for today. I did see the poll results before I started my screen share. And I think the majority said that they do selective FMR, I think without composites. Or
yes,
was it without composites? With composites?
With composites is 71% and 28% is no without composites.
Okay. A kind request, all of you all who have done FMRs with composites, could you please just type in the chat box, what was your experience? Did they last? Did they break? How long did they last? What were the issues that you faced? Because I can discuss them during the presentation or afterwards in the Q&A. Dr. Urvashi, if you find anything interesting in the poll box written regarding composites at the appropriate time, if you could just interrupt me because I cannot see anything else right now.
Definitely, ma'am. I'll interrupt you once something is there in the chat box.
Because now that I'm on the screen share, I can't see anything else. Okay. So our topic for today is FMR. Yes. Now, there are many ways to do a full mouth rehab. Okay. The old concept of doing FMRs were we prepped all 28 teeth. We raised the VD 2 to 4 mm. We crowned every single tooth, or we gave an FPD, 3-unit FPD. And that's how we did our FMRs. But concepts have now changed. Okay, now we have adhesive dentistry. We have better materials. So even if one chooses to use zirconia instead of lithium disilicate, because the occlusion is such that they aren't comfortable giving lithium disilicate, you do have better materials, which does improve the bond of zirconia to the tooth. I will not say that it is equal to lithium disilicate, because it is not. But yes, it is definitely better than simply luting it with GIC. So there is actually a classification of full mouth rehabs, and it's not something that's discussed very often, but there is a classification by Turner and Misiran. And there are 3 types of FMRs actually. The first FMR is when you there is a loss of occlusal vertical dimension, and there is enough space available to do an FMR. So now this is the easiest type of FMRs. The second and the third get a little tougher, with the third being the most tough. In the second one, you have a case where there is loss of occlusal VD, but there isn't sufficient space to go ahead with the FMR. And the third is there is loss of occlusal VD, and there is no space also, or the space is very limited. In short, you have to do the FMR, but you cannot actually raise the VD of that patient. So the third one is the most difficult. I mean, how do you do an FMR without being able to actually raise the bite? Okay. The third is the most complicated among 1, 2, and 3. In 1, there is space available. You can easily raise the bite. In 2, the space is available, but it is limited. Okay. And in 3, there is no space available at all. So sometimes we see, we kind of see combinations. Okay. A particular case need not be entirely class 1 or entirely class 2 or entirely class 3. We could have the anteriors or the posteriors falling in one particular class, and we could have the other aspect of the mouth falling in another part of the class. So they become very complex FMRs, okay, because you have one classification being adapted to, say, the anteriors, and you have another classification for, say, the posteriors. Now, why am I sharing this? It may or may not be entirely pertinent to our webinar today, but I am sharing it because when, as a mentor, I'm taking up a particular topic and I'm teaching a particular subject and I'm taking a webinar on it, I believe in being thorough and concise. And you never know when and where you would require this information, because, as I said, when we see a case in front of us, we need to first understand in which classification the case falls, and only then we can formulate a treatment plan, and every case is different. So in this particular webinar, I have actually included more written matter than I usually do in my webinars, and that's because the topic is such, the case is such, and I left the matter so that if anybody wants to take notes, they can, because it would not be possible for me to speak so much and to cover so much in the limited time that we have in our webinar. So, okay, so this particular case is about a 66-year-old gentleman. And for a background, this case took place right in the middle of COVID. Now, why is that important? That's important because I had no access to the lab at that point, because we have to remember that, the labs were asked to work on minimum staff. So they had very, very less staff, and they were completely overloaded with cases. And yes, we were told not to work unless it was an emergency. But for this particular patient, I had to take up this particular patient because he said my crown was dislodged. Now, see, I thought it's just a crown cementation, and a thing like a crown cementation, you cannot be without doing it immediately. You cannot tell the patient, okay, you know what, you come to me after 2 months after the lockdown is over, because the crown is not going to fit anymore. All right. So when the patient said that I needed a crown cementation, also the patient was known to my family, so I could not really turn the patient down. So I said, okay, fine. But when the patient walked into my operatory, this is what the patient presented with. And, it was just a single crown. But then when I looked at this case, I realized that, oh gosh, this cannot be treated as just a single crown. This is actually an FMR. Now, why do I say that? Because if you see this, the vertical height of this tooth that is available is actually very less. and the patient gave a history of the crown dislodging or fracturing every 2 years. So the crowns never lasted. Now, whenever a patient says that a crown dislodges, it's because there isn't sufficient retention. And usually the lack of retention is due to insufficient crown height. But if a patient says that the crown fractured, then 100% there is an issue with the bite of the patient. So if a patient is giving me a history of fracture of the crown, twice every 2 years, it really doesn't make sense to fabricate a third crown in the same occlusion only for it to fracture once again. Now you can see that the patient has an anterior deep bite, okay, and also a cant. You can clearly see that the plane of occlusion is tilted this way. So it's obvious that this patient has a tendency to masticate, more towards the right, because the entire midline of this patient has shifted to the patient's right side. And, you can see that there is, the adhesion of the incisal edges. Okay, so these are all signs that the patient needs an FMR. There is loss of vertical dimension in the posteriors. There is shift in the midline, indicating that the patient is chewing more on one side. Therefore, there is more wear on the occlusal surface of one side, leading to a cant. And there is adhesion of the incisal edges. Now, for all those of you who have attended my previous webinars, you would by now know that if there is adhesion of the incisal edges, it means that the anterior guidance is a problem. So this is not that can be solved by just re-cementing that, or refabricating that one crown. And when the patient came to me, the crown was fractured. So there was no point in re-cementing it. I had to make a whole new crown. Now that is again another issue, because we cannot tell the patient to sit without a crown for 2 whole months. Whatever little abutment height I have on the tooth, I would end up losing even that with gingival growth in those 2 months. So now I am faced with the prospect of a big case in the middle of COVID without decent lab support, because they themselves are very understaffed and very overworked. Okay. So these type of cases are very difficult to manage under such circumstances. So let's see how I went about it. And I'll be very, very honest. When I started out this case, did I know that it was going to end well? Or did I know that I was going to like how it ended? Or did I know that I would be successful? No, not at all. Okay, this happens in a lot of FMRs. You have a plan in mind, yes, but then you have to execute it. And only when you come to the final conclusion, when you come to the final occlusion, can you say, okay, fine, it's a case well done. If you ask me in the beginning, I have no idea. I'll be very, very honest about that part. So now when you see the occlusal surfaces of the upper teeth and the lower teeth, the upper teeth were okay. They didn't show that much of wear. But then when you see the lower teeth, there is so much of wear. This premolar is completely gone over here. You have wear on this premolar too. You have wear on the canine. This is of the patient's right side. This is of the patient's left side. So this is a crown. There is wear on this molar. Now, this is the other premolar, and this is the canine. So there is a lot of adhesion that we are seeing in this case, a lot of intrinsic staining, okay, because the patient drinks numerous cups of black tea in a day. So, these stains are intrinsic. There isn't much that anybody can do anything. And yeah, severe sensitivity, extremely severe sensitivity the patient had. So, considering all of this and the fact that I didn't have lab support, I actually used composites in an FMR case for the first time in my life. Okay. I am not a fan of composites in full mouth rehabs. Why? It is very simple. There is obviously an occlusal issue with most of these patients. Most of these patients are bruxers to some extent and to some degree. And even crowns aren't going to last in a bruxer. They wear through all their enamel and they come down to dentine. And in such situations, composites are definitely not going to last. So composites can always be considered as a short-term solution, but they can never be a permanent solution. Okay. So I know that a lot of people do FMRs in composites because, as I said, it's a short-term solution, and sometimes the patients aren't affordable, and you want to finish or you want to terminate the case in good occlusion, and so that the patient does not have all the expenses at the same time. And I do sympathize with that. But on the other hand, as a clinician, okay, when you terminate a case in composites, the problem is that that occlusion is not going to last. Okay. So what's going to happen is that you in effect end up having to either keep on repairing the chips and the breakages of the composite if the patient comes back. Sometimes the patient doesn't come back and simply wears through them. So by the time the patient comes back and is probably ready to do crowns or realizes that this is not going to work out, you have to completely redo the FMR. I mean, doing it once is difficult enough, but imagine doing it twice on the same patient. So this is the reason why I really do not prefer composites, and I always go with indirects as much as possible. But this case was really, really different, and I didn't have access to a lab. See, now, ideally, what should I have done in a case like this? Very, very ideally, made an upper and a lower impression, taken a bite, sent it to the lab, told the lab to scan it, and design the entire occlusion in the CAD, send me the CAD so that I can check, raise the bite in the CAD. Okay. And after that, I would do the crown preps. We would temporize the patient. And if the temporary was fine, and I would check the aesthetics, the phonetics, the vertical dimension, and the occlusion. And if everything was fine, I would proceed to the permanent. But I couldn't do any of that because the lab clearly told me that if I sent the cast for the CAD, I would have to wait 3 weeks for me to just get the CAD back. So that's like an utter waste of time that we didn't have. Okay, so I decided to do what I expected more or less from the CAD, chair side. So what I basically did was raise the vertical dimension chair side, okay, on both the right and the left by adding composites. So I added composites here, okay, here on the crown too. Now see, adding composites on the crown was never meant to be permanent. I did it only because I wanted to recreate a good plane of occlusion, because that makes the lab work easy. They don't have to sit and design an entire CAD with a proper plane of occlusion, and they don't have to do all of that. All of that would have already been done by me and given to them, and they just have to just design only the crowns. So it makes their chair side time in front of the computer far less than what it would take, because when it takes a lot of time to design the CAD for an FMR case. It takes a lot of time. Okay, time that they did not have. So I built up right from this canine to this molar. Okay, and now the next question is, how did I manage to add composite on crowns, because it's not going to last, and everybody knows that composites do not adhere to a crown. And how did I do it? So what I did was, for the crown in particular, is a PFM. So what I did was, I used finishing burr and slightly created micro abrasions in the crown, and that's okay because the crown anyway needed to be replaced. And after that, I used the universal bond with 10 MDP from Kurari, and this is a bond which can actually be used to bond to ceramics also. Okay, this bond is indicated for that. I use that bond. Now the composites that I have used in this case are nothing fancy. They aren't something very superior. They aren't bulk fill or anything like that. They were normal restorative microhybrids from Ivocla. I did not waste material, very expensive material, because these were all meant to be temporary any which ways, and it didn't make sense. Okay, so that's why this case is very interesting, because even with this approach, I did manage to get very good results, and I was very, very happy. So I didn't really need a bulk fill also in this case, because when you are adding composite on the edge of the tooth or on the edge of the crown, when you're basically creating a cusp. See, this is very difficult chair side. I had no template. I had no wax up. I was pretty much doing it freehand, chair side, with composites. Okay, this requires experience. It's not something that anybody and everybody can do. But the reason I'm able to do it is because I have done a lot of teeth arrangements, right? As a prosthodontist, we used to do all our wax ups ourselves. We used to do a lot of teeth arrangements. So I'm used to building up a plane of occlusion and used to building up a curve of speed. But that doesn't mean it was easy for me, because when you are in private practice, okay, to a large extent, you lose touch with all of that because as a student, your life is different. You're doing all the lab work yourself. But as a clinician, your life is different because you are now outsourcing all of your lab work. But some things are ingrained in you mentally, and there is a memory pattern, and if you're forced to do it, if the push comes to the shove, if you have to do it, you can do it, your hand will work. And that's what happened. And I made sure that I polished these composites really, really well, because I didn't want the margin of the composite getting all rough, and then the patient getting irritated and trying to remove plaque or something getting stuck over there and then dislodging the composite. So it is very, very important to polish these composites really, really well. Okay, so now this is the vertical dimension on the left side of the patient. Now I did the right side. I did first the right side and then I did the left side. Both were done in the same appointment because you cannot raise the VT on one side and send the patient home. Okay, it's very uncomfortable for the patient. So it was a very wrong appointment. And chair side, I first did one side and then I did the other. Okay. This is now what happens is when you raise the VD on one side, you obviously get an open bite on the other side. The pertinent question is, by how much should you raise the VD, right? Because traditionally, we would have done a phase bore transfer, taken it onto an articulator, and then you judge on the articulator how much is the interocclusal space that you need, the bare minimum, to fabricate your indirects, and you raise the space according to that. And then you also raise the space according to the minimum overjet and overbite that you need. Okay, but here I'm doing everything in the mouth. So I raised the bite around 2 mm approximately. This should be around between 2 and 2.5 mm. Now, again, when you've done a lot of lab work, or when you've been doing a lot of crowns and bridges for many years, you can judge that this increase in vertical dimension is more than enough for the replacement of this crown, and to close the occlusion. Okay. Now, this is a selective FMR. Now, why am I calling this case a selective FMR? For one thing, the patient had existing crowns and bridges. Okay, he had it 1, 2, and 3 here, and he also had it on his right side. He had the right side, the first quadrant, the right side, fourth quadrant, as well as his, the second and the third quadrant. All the occlusal surfaces of all these crowns were worn off. They were all fractured. So the patient didn't come to me with just one missing crown or one fractured crown. The patient came to me with all existing crowns also fractured. Second of all, this particular patient is a deep bite. So whenever you have a case with a deep bite, okay, you can judge. If there are cases where the deep bite is so severe that even if you raise the VD of the patient by 2 mm, you would still have the average overjet and overbite. The reason that the patient developed the deep bite in the first place was because of collapse of the vertical dimension in the posteriors. If the case is like that, you can actually do an FMR selectively only in the posteriors without involving the anteriors at all. And that is what I have done in this case. I have not involved the upper and the lower anteriors per se, but yes, I have built up the distal cusp of the canines. So the canines were the only anterior tooth that I have touched, and that too with composites. Okay, I have not done indirects on them. But apart from the canines, I have not touched any of the other anteriors. The premise being that the severe anterior deep bite was created due to a lack of vertical dimension posteriorly. And once you restore the vertical dimension posteriorly, you can correct this anterior deep bite without actually touching the anterior teeth. Okay, so this again, this, as I said, this is a complex FMR because you have different classifications applied to different areas. You in the posteriors, you can probably say that you have loss of vertical dimension, but you are having enough. There is loss of vertical dimension, and you're creating the space required by raising the bite. Okay, but limited. It is limited. As you can see, it is not too much. It is limited. Why? Because I don't want to prep every single tooth in the arch either. I'm trying to do a selective FMR, and normally when we do selective FMRs, we try to involve only one arch sometimes. The arch which is most affected. So sometimes if it's the lower teeth which are completely attreated, we may give overlays on all the lower teeth and raise the bite and close the occlusion, but we may not touch the upper teeth. So in that case, it would fall in classification 2, where there is a loss of VD, but the space available is limited because you're raising the bite in a limited fashion. Now, in this particular case, it was a mixture because he already had pre-existing crowns both in the upper and in the lower. So I had to change this crown. So I could not tell the patient that I'm not going to touch this arch at all, and I'm only going to touch this arch, because it would not work. Up to the premolar, these natural teeth were fine, but then the crowns were fractured. And all these posterior teeth right from the canine, they showed atresion. So it's a little bit of everything in this case. So I established contact on the left. So I started with the canine first. Okay, I added composite here, and I added composite over here. I then added composite on the buccal cusp of this premolar. I didn't add composite over here on this crown because it was just too much to build up, and I didn't think that that it would last. So I left it over there, and I also didn't end up building up on this crown and this crown over here because it's completely flat. See, even when you try to build up with composites, there has to be some type of cuspal anatomy on the crown for you to build up. You cannot build up cuspal anatomy and try to close it in occlusion if you have a fractured crown which is completely attreated and flat. It's not going to work out. So we also need to know where we can do it. So that's why I did it on the patient's right lower molar, because it had some anatomy, but I did not do it on these crowns over here because the anatomy is completely gone. But see, at the same time, I need to give the patient some sort of vertical stop on the patient's left side also, because see, it's very important that the patient has a vertical stop on both the sides. It's not enough if you give the patient a vertical stop only on the right and do not do it on the left. Why? If the patient does not have a vertical stop bilaterally, what happens is there is always some amount of movement in the horizontal plane. So the bite of the patient is never constant. It's going to keep changing. And then it's not possible to establish the position of maximum intercuspation in that patient and then go on and complete the FMR without issues. So that is the reason why you need a vertical stop. So how was I going to provide that vertical stop in this case? So I provided it here. This was one point of contact. So when there is a rule, even in vertical stops, we say ideally we should have 4 contacts. But if you're unable to have 4 contacts, then you should have at least 3 contacts, which is minimum. So this is the first set of contact. Okay, my first premolar is my second set of contact. And what I did was I actually added this lip of composite over here. I had every plan to remove it later on. This was done temporarily just to provide a vertical stop for the patient to be able to close accurately in MIP consistently, repeatedly, without any shift in the horizontal plane. So I added composite here, and this became my third point of contact. Okay, so I have 3 points of contacts between the canines, the first molar, and the first premolar. And that was enough. That was enough temporarily for a short period of time till I could finish the right side and I could come to the patient's left side. Again, all of this was done chair side, and it was done in one appointment. So after this, what did I do? After this, I analyzed. I looked at the the teeth from the frontal aspect, because sometimes that's very important. So now you can clearly see that the plane here seems more or less okay. This is not in the plane because I did not build this up, and then I have this and this seem to be at the same plane, but then not this. So these are all things that I would now have to fix later. So I have canine, premolar, and molar is supposedly in one plane, and this is out of occlusion. Although I said that I would not be involving the anteriors in this case, you don't need to note this, and you can see the wear on the incisal edges. So this is something that I kept in my mind, because this is going to determine the type of mutually protective occlusion that I'm going to give this patient later. Now, when there is already wear on the incisal edges, I will not be giving the patient the typical mutually protective occlusion, which is edge to edge, where the upper and the lower anteriors actually come edge to edge. I will not be doing that. I will be terminating it a little short of the incisal edges, which means that the posterior disocclusion in mutually protective occlusion will be a little less. But that's okay, because I do not want to involve these teeth. So sometimes these are notes, mental notes that we need to make to ourselves, and keep it in mind when we are fabricating the case overall, even if we are not involving the incisal edges of the anteriors. So now this is the pre and the post increase in the VD. So you can see here a total midline shift to the right. And you can see that after I increase the VD on both sides with composites, the midline has almost come back, in the center. Okay, now whether his midline was always a little, it's still a little, slightly off center. But many patients do not have their midlines coinciding exactly. They do have a little bit of deviation either to the left or to the right. And I cannot be very sure if the patient's original midline was an exact coincidence in the center, or whether there was always a slight deviation. But anyway, it doesn't matter. This is good enough. Okay. Another important function that these composites played, they gave a starting point for the lab, and they didn't have to sit and waste their time designing the plane of occlusion. The other thing also that played a role over here is patient acceptance. It played a very, very important role in patient acceptance. FMR patients are very difficult. Okay, the case is difficult. Giving the patient good occlusion is difficult. Everything is difficult. But even convincing the patient to undergo the treatment is very, very, very difficult. Okay, so for some patients, it's the finances. For some patients, it's not the finances per se. It's just the idea of coming for prolonged treatment, investing so much of their time, coming and sitting in the clinic for, long appointments for a duration of 1 to 2 months. It seems very daunting for them, okay? Because ultimately, it's a major dental treatment, and everything said and done, any major treatment requires that much investment of their time, which means they cannot do a lot of things. They cannot their social life or whatever, they have to set their other priorities aside and make this their topmost priority. And that is something that patients are very uneasy about for various reasons. For some patients, it's their age. Okay, for this patient, it was his age. He said, "See, I'm a senior citizen, so whatever treatment you are telling me, you please think about it. Okay, at my age, I will not be able to sit and get so much done." This was what he said to me in not so many words. I very honestly told him, I said, "Sir, I completely understand what you're saying, but to be very honest, all your crowns are fractured." And why did that happen? Because every dentist in the past had simply given him crowns at whatever VD and whatever occlusion he had. Nobody ever bothered to correct the bite. Now, whether it was because the patient refused, or whether it was because the clinician didn't want to get into it, I don't know. I only know the facts. The fact is that every single crown in the patient's mouth had been done at various times, and they'd all been done at whatever VD and occlusion the patient had at that point. Okay. So I said that is one of the reasons you are in this position today, because that this intervention was never done in any of your previous dental appointments. And now we've reached a stage where I simply cannot give you crowns anymore at whatever bite you're having, because you yourself are saying your crown is fractured twice. We do it, it's going to fracture a third time too. And it just doesn't make sense in you putting in that kind of money. And, we are talking of, and if you do not replace your fractured crown, his teeth were all RC treated. I said, you can always have reinfection, and that's just going to lead to more headaches and more problems down the line. Imagine then, you have to do retreatment, and then when you have to do retreatment, you will any which ways have to replace these crowns. But then by the time you would have had so much of unnecessary pain and suffering. So that is one thing. And the second thing I told the patient was, I understand your age, and I'm keeping your age in mind. If we do not do the right treatment, see, there is always the right treatment and then there is a shortcut treatment. So the shortcut treatment can get you only so far, and then beyond that you reach a stage where it's not going to work anymore, and you've already reached that stage. So if you want a relatively pain-free and stress-free life, at least where your dental treatment is concerned, get it done right. Get it done right now, so that you're fine for the next 10 years. Because today you're 66, and if you feel that you cannot do it now at this age, trust me, it's going to be impossible for you to do it as your age goes ahead. It'll be even more tougher for you to get it done at 68 or 69 or at 70 or 72, because the mindset is going to become worse. You're going to feel more and more aged, and you're going to feel more and more like you can't do it. So if you don't do it now, then I don't think you'll be able to do it later. And I said it very honestly and very sincerely to the patient. This is honestly what I believed. The patient grumbled and mumbled and grumbled and mumbled. And there was a lot of, I will think about it and whatever. I said, okay, fine. So I raised the bite in composites, and I made an impression only for that one single tooth. And I kept telling the patient, it's not going to last. It's not going to last. It's going to fracture, but I'll raise the bite and show you how it is supposed to be. The bite at which you are chewing, the height is too less, and you're applying too much force on your crowns, and it's going to fracture. So I raised the bite. I sent him home. Meanwhile, we got the crown on 4/7 fabricated. Okay, I took, but to be on the safe side, I did a phase 4 transfer. I took a protrusive bite for this particular patient. Okay, and I transferred it to the semi-adjustable articulator just to be on the safe side. In case the patient agrees, in case the patient changes his mind, then I don't need to call the patient back and do all these procedures. And I sent the patient home with a raised VD, and I said, we'll talk about it when you come next. Okay, so let's just park that thought for the time being. I'll come back to what the patient said to me when he came back, when we come to that slide. Since we are at the slide of the semi-adjustable articulator right now, I want to talk about the semi-adjustable articulator. If you noticed in the previous slide, I had taken only a protrusive bite. You can see this. Can you see this over here? This is edge to edge over here, right? So I have made a bite on the left and on the right with the upper and the lower anteriors in an edge to edge position, which means that this is a protrusive bite. Always when you make this type of bites, please take a marker and mark them. Put an R for the right and put an L for the left, so that there's no confusion where the lab technician is concerned. I do all these things. I don't really expect the technician to think much, especially when they are understaffed in the lab. And bites should be made in aloe wax. I really do not recommend bites being made in any other type of wax, especially modeling wax. Okay, it's too soft. It distorts. It distorts with and it releases stresses and it distorts, and it's just not going to work out. Aloe wax maintains the same rigidity once it's cooled down. Okay, till it reaches the lab, and the lab ends up mounting your case. So now now there are two types of bites. Okay, you have bites in lateral excursive, and you have a protrusive bite. Now the protrusive bite will give me the condylar angulation. Now again, I mentioned this in my earlier webinars also. So patients usually fall in 3 categories. Okay, you have high, medium, and low condylar guidance. So low condylar guidance is around 10 degrees, where the patient, you usually see that in complete denture patients, or patients whose ridge is completely flat, undergone severe iteration, end up giving them monoplane occlusion, because honestly the ridges cannot take anything else, and the retention of the dentures is very poor. In fixed denture patients, you go somewhere between medium and high. High is 30 degrees and medium is 20 degrees. Now, the decision between whether you want to go medium or whether you want to go high or something in between really depends on a lot of factors. See, traditionally, okay, all prosthodontic textbooks or all textbooks on occlusion, they say that the condylar guidance is the one thing that you cannot change. That's the one parameter which you cannot change. That is something that the patient gives the operator, and everything else can be manipulated by the operator. You can manipulate the cuspal inclination, you can manipulate your plane of occlusion, but you cannot alter the condylar guidance. So that is one school of thought. Um, you know, based on clinical experience, there is another school of thought. This is something that my guide taught me back then. And, sometimes when you have these type of cases and you know that the patient's, the masticatory force is too much. And by the way, the patient did have hypertrophy of the masseter on the right side. Okay. I did not take an extraoral picture because the patient was not comfortable with his face being visible. But yes, the patient did have right masseter hypertrophy. So see, it's very obvious that the bite is very heavy for this patient. His chewing force is far more than normal, probably a Bruxer 2 or a grinder in the night. Okay. So for these patients, sometimes it's okay to reduce the condylar guidance a little bit. Instead of giving the patient a 30-degree condylar guidance, you can give the patient a 25-degree condylar guidance. Why? How is this going to benefit the patient? Why am I doing it? The reason is because your cuspal inclination is directly proportional to your condylar guidance. The steeper your condylar guidance, the more will be your cuspal inclination. The more is the cuspal inclination, the more chewing force the patient will be able to generate. So if you want to reduce the amount of chewing force for certain patients in order to protect the prosthesis, you need to reduce the condylar guidance. So when you reduce the condylar guidance, automatically your cuspal inclination also reduces. Okay, so that is one way of saving the prosthesis. Now, I didn't apply that here. Now, I'm giving that information why, even though I did not use it in this particular case. Because as I said, FMR cases are very complex. You never know what you have to apply and where and to which case. And every single case is different. In this particular case, I took the patient's condylar angle. By experience, when you see the patient chair side, you can easily make out if the patient is 30 degrees or if the patient is 25 degrees. Most FPD patients are between 25 and 30 degrees. Okay. I knew that the patient was 30 degrees. So it was not a very big surprise for me that the angle that I got on the articulator was 30 degrees. Despite my entire explanation earlier, I still kept a 30-degree condylar guidance for this patient. The reason why I did it was because I was not involving the patient's anteriors. If you remember, I had said we need to make a mental note. There is attrition of the lower anteriors. There was that picture where the entire lower arch was visible after I had built up the composites, and you could clearly see the wear on the lower incisal edges. And I said, this is something we have to keep in mind because it is going to affect the way we do our case, especially since we are not involving the lower anteriors. So since I'm not involving the lower anteriors, I'm also not going to bring the lower anteriors and the upper anteriors in an exact edge-to-edge position in MPO. I'm going to terminate it with a slight overjet and overbite so that attrition or abrasion doesn't worsen, which means I will have less disocclusion in the posteriors, and this is something I had mentioned earlier. So when I'm having less disocclusion in the posteriors, I cannot give the patient a 25-degree condylar guidance because then the disocclusion would become even more less. So that is the reason for this particular patient, I stuck to the 30-degree condylar guidance, because for this particular case, it would end up giving me only the minimum amount of disocclusion. And even with the 30-degree condylar guidance, we could still give the patient not a very steep, cuspal inclination. And you will see how I achieved that in the future slides. So now, this crown had now come manufactured from the lab. The patient came to me in this appointment. And this was the appointment where the patient told me, you know what, I understand your point. Go ahead with whatever you told me, because now that you've raised my bite on both the sides, okay, I'm actually able to chew better. Before, I had to apply a lot of chewing force, and I never realized that that's not the done thing, or I shouldn't do it, because you don't know what you don't know, and I didn't have anything to compare it with. But after you have raised my bite, I actually feel far more comfortable. So please go ahead. and his right masseter hypertrophy had started to visibly decrease. Okay, and he fractured this. So I rebuilt this too one more time. Okay, this was fractured. So these things are expected when the occlusion is settling down. The composites will keep fracturing. Um, so since he gave me the go ahead, I cemented this and then I cut this out. Now I only cut this one crown out in the appointment. I did not cut this and this out. Why? The reason is because this is the terminal tooth in the mouth, and I had built up the plane of occlusion from this canine to this premolar, and then if I cut this crown out again, I would lose that that build up. And as I said, I didn't have very good lap support at that point, so I wanted to create a terminal vertical stop with one more crown here before I cut this crown and this crown out. Okay, so what I did was I built up composite here and closed the bite. I built up the composite here. I built up the composite a little bit more on the canine here. Built up the composite here on this premolar and on this upper premolar, and I closed the bite. So I basically created a plane of occlusion. Okay. And it was only after I did this that I made the impression for this tooth over here. Now, one thing I want to mention is when you have these type of cases where you're doing selective FMRs and you're not involving the anteriors and there isn't going to be too much of disocclusion in NPO, okay, you will not have a very typical plane of occlusion where you actually see a very, very steep curve from the canine in the anteriors to the molar in the posteriors. You will not see that. At the most, in these type of cases, you kind of get a straight line or a straight plane, and that's okay because at least it's not in reverse. Okay, and that's fine, because again, for this particular patient, I didn't want to give such a steep curve, because if I'm going to give such a steep curve of SPE, then I would have to give very steep cuspal inclinations too, which is again going to impact the amount of chewing force he could generate, which I did not want. Okay, I want these prostheses to last. I don't want any more breakages. So therefore, by reducing the curve of SPE, by reducing the plane of occlusion and the cuspal inclination, you can increase the longevity of the prosthesis in certain selected cases. I made the impression for the upper and the lower. Okay, these are the impressions on the right. And initially we designed only this, as you can see. Now you can clearly see in the CAD. See, whatever I did chair set. Okay, they do say that the mouth is the best articulator, and it is true. It is not wrong. The mouth is the best articulator. But when I saw the CAD, I can verify if what I did was correct, because the CAD allows me to do certain things that I cannot do in the mouth. For example, I cannot visualize the occlusion from the posterior the way you can on an articulator. You cannot do that in the mouth. I can literally spin my CAD around 360 degrees and visualize it in whichever way. I can see the amount of intercuspation. I can see whether it's tight, whether it's medium, whether it's a light contact. I can do a lot more with my CAD. But it is very, very clear over here that this plane of occlusion is acceptable. Okay. And, this, and it's also, the tech also confirmed that this amount of open bite over here is sufficient for him to change this prosthesis, and this prosthesis. So, whatever I decided through experience chairside was accurate. It was confirmed by the technician that this amount of BD is enough for him to go ahead with fabricating the final prosthesis on the patient's left side. This chipped when they poured the cast and then they mounted it. So just ignore that. This is when all the crowns in the posterior have been replaced on the right. Okay, we have replaced 1, 2, 3, and 4. So we have 4 molars. The premolars are in composites. The canine is in composite, and these crowns have actually been made with different materials. This is monolithic zirconia, and the other 3 were PFM. And I used monolithic zirconia here because when this crown was fabricated, at that time, the patient had not yet consented to his FMR. So although I had raised the bite with composites in the hopes of converting the patient and showing him the difference, I had very little interocclusal space to work with. And if the patient didn't agree, or I would have had to just stop there, and then I did not want the crown to fracture, and I felt monolithic zirconia was a better option than going for anything else, at least less chances of fracture. So that was one of the reasons I went for monolithic zirconia here. But once the patient decided that okay, he was prepared to go in for the FMR, that's when the budget starts to come into account. So we were, FMR cases do break the bank of the patient sometimes. It's just a lot of crowns. So to keep the budget under control, we went for PFMs in the other crowns. He had PFMs in the past, and we gave him PFMs now, but they are CAT-CAM. His earlier PFMs were non-CAT-CAM PFMs. They were the PFMs that were made, by waxing up freehand, also known as the lost wax pattern. These PFMs have been made CAT-CAM. This is not DMLS. DMLS is different from a CAT-CAM PFM. DMLS is laser sintering of the metal, and a CAT-CAM PFM is, when the lab actually mills the coping in a plastic material which can burn out in the furnace. So the plastic coping is like the freehand wax pattern that the technicians used to do in the past, and it burns out in the furnace without leaving any residue. A CAD-CAM PFM is a little cheaper in the lab cost as compared to DMLS, but function-wise, there's no difference, okay? You get the same fantastic fit, you get the same long-lasting prosthesis. And we stained these prostheses to match his natural teeth, and you can see the match is actually really, really good. It's very difficult to make out which is a crown and which is this natural tooth. But the patient felt that they were too dark and they were too brown. And so, when we came to the right side, we didn't replicate it to that extent. We kept the patient happy and we gave him a lighter shade on the patient's left side as compared to the patient's right side. So this is the comparison, okay? Now this is very subtle. Very, very subtle. When you see the posterior here, you can't make out much difference, but the difference is here in the anteriors. You can clearly see that the vertical dimension has been increased in the anteriors over here, okay? And the scant, because you can see the scant has now disappeared, all right? So the difference is very, very subtle in such cases between the pre-op and the post-op. It's definitely there. When you look for it carefully, you do find it. Fine. Now we come to the patient's left side. Now, there was a tricky caries resto that I had to do. Why am I talking about it? How is it pertinent to the FMR? It's actually pertinent to certain concepts of crown and bridge. And I decided to include it because, this is something that I see very often chairside when the patient comes with a crown fabricated elsewhere. You typically see this with this non-CAD-CAM PFMs, the handmade PFMs, okay? The fit is not accurate naturally because it's handmade. So there's a lot of adjustment, chairside adjustment which happens, and very often clinicians arbitrarily adjust the proximal surface of the crown, and they also disc the proximal surface of the adjacent tooth and they fit the crown. But then there are long-lasting repercussions when you do that, as what is seen over here. You can see this, the decay over here. And the decay is not visible from the occlusal surface. It is over here. It is below the cervical margin, and it's interproximal over here. And whenever you see these type of weird shadows between two teeth, you should suspect that there is decay over there. And it was impossible to reach it from the occlusal. And I'm showing this in black and white rather than in color, because in color you actually could not make out the decay. It wasn't that visible, but when the photograph is in black and white, you can clearly see this decay over here. It was completely inaccessible from the buccal, completely inaccessible from the lingual. If I had to access this decay here, I would have to cut a lot of this tooth structure, and I was not interested in doing that. Okay, it was better to replace this crown, which anyway we are replacing. In this FMR, we anyway need to replace this crown. So why would I cut this tooth structure over here? Now, even if this was not an FMR, if it was another patient, I would always tell the patient, look, it doesn't make sense to cut your healthy tooth structure for this cavity when the problem is actually just this adjacent crown. You replace this crown, and once we remove this crown, I will gain access to this cavity and I will be able to fill it up. And then we fabricate the crown correctly so that you do not have this problem again in the future. That is the correct workflow. So we cut the crown out, and I had to really, really build up, the tooth 3.5 and 2.6 and 2.7, because there were a lot of undercuts, preparatory undercuts, and it's not possible to go ahead and fabricate a CAT cam a PFM without blocking them out. And if anyone has ever tried blocking undercuts in the prep with composite, especially if the undercut is at the margin of the axial wall, it's at the junction of the axial wall in the margin, you would know how difficult it is. And composites are very irritating because when as soon as you use a finishing burr and you try to smoothen it, you end up chopping off far more than is possible. So what I have used over here is another material. I have used Wonder Edge DC 3-in-1. It's actually a core build-up material, but it's 3-in-1 because you can use it for luting a post, you can use it for core build-up, and you can also use it for crown cementation. And that material is pretty hard. Okay, once it's set, it actually lets you prep like enamel. So I don't end up doing double, triple work where I end up first adding composite, then trying to smoothen it, then nicking the tooth accidentally and again creating an undercut, and again adding composite. It's very irritating. Or what I did was just syringe Wonder Edge DC around these teeth, and then I prepped it like how I would prep a tooth. And that's how I managed to do it in minimum amount of time. Yes, but you do require material. I ended up adding material on the occlusal surface and on all the axial walls also, wherever the undercuts were. I didn't add it 360 degrees. I added it wherever the undercuts were present. It's light cured. And then after that, I prepped it. And that's how I got this. And, I ended up filling in this resto. The finishing and the polishing was remaining. Okay, when this photograph was taken, it has been completed in the subsequent photographs. The impressions are made in monophase. I do not use putty and light body. I only use monophase for all my crown and bridge work. In fact, for any impression, I use only monophase. Monophase is a very versatile material. You can use it in implants, you can use it in crowns, you can use it in bridges, you can even use it in your FIs in complete denture. So it's one material for everything. But yes, there is a learning curve to using that material. The advantage of monophase is less inventory because you have one material which you can use everywhere. The second advantage is, see, putty and light body again takes, either you need an assistant. So one person is mixing the putty and the other person has got the light body ready, and you make a single step impression. Otherwise, you need to be really, really fast to be, to be able to do it yourself without an assistant, or you need to do a double step where you place a spacer on the putty. Either you have to place a spacer or you have to cut it out. All of this is extremely time-consuming chair side. Okay, especially in such long appointments when everybody is tired, you're tired, the patient is tired, everyone is tired. So monophase is just it's a single step material, and I always make sectional impressions. I never make full arch impressions. Why? Two reasons. One is, frankly, you don't need full arch silicone impressions. You need silicone impression only on the prepped teeth. If you're going to make full arch silicone impressions, you're frankly just wasting material, and these materials are very expensive. Monophase is more expensive per impression as compared to putty and light body. So I only use a sectional tray. Okay. Of course, if you use the sectional impression, the lab tech needs to know how to superimpose. So every time I give him one sectional impression, I also give him an alginate full cast. And then he scans the full cast, but then he will superimpose this sectional impression, the cast which he gets from the sectional impression onto that full cast. Okay. So the lab tech has to know how to do it and should be willing to do it. And not all labs and lab techs are willing to do it. So you've got to find a lab who does it. So that's one thing. The other thing is, monophase works only if your margins are equigingival. You cannot expect monophase to work if your margins are subgingival. Now, I never give subgingival margins in general. Okay, I do not like to violate the junctional epithelium. If the margin is subgingival, it is in very rare instances where there were subgingival caries. The furcation is exposed, and including the subgingival caries into the tooth prep, or I need to go subgingival in order to increase the abutment height to increase the retention. So those are very few cases and far between. But in general, my preps are always equigingival and I do not go subgingival. That doesn't mean my crowns are short. They are never short. Monophase will pick up even knife edge margins. Now see, these preps were already done earlier by some other clinician years ago. And you can see that the margin is very, very thick because see, these crowns are 10 years old. They were a decade old. So, the concepts then were different. The concepts now are different. But when I prep a tooth, I actually leave the margins knife edge. I do not make heavy chamfers or heavy shoulders, and I don't do any of these things. I try to give a knife edge margin and it gets picked up very beautifully in monophase, and the crown fit is very accurate with CAD-CAM. Again, I can do this only if the workflow is for a CAD-CAM. You cannot give a knife edge margin and expect the technician to be able to give you a decent crown if it's a handmade PFM, using the lost wax technique. So can you see this pink area over here? Yeah, the pink area is the superimposed part of the cast. So this yellow part of the cast was the original full arch cast, which I'd given the lab, which I'd poured from alginate. And the pink part is the sectional impression cast, which the technician has superimposed. Okay, so it saves a lot of material and time chair side. And the other issue is when you go for full arch silicone impressions, there is always a drag somewhere. See, it's very, very difficult to get all the teeth in the arch properly in silicone impressions without any bubble, any drag, anything anywhere. It's very, very difficult. And more often than not, you don't get it in your first try. So you end up discarding the impression and you end up having to take your second impression, sometimes even the third. So you can imagine the amount of material wastage that goes on in the clinic. So compared to that, when you use monophase and that too sectional, you really do save on material costs. Now, these are the finishing touches. Okay, I have included a radiograph to show the contact over here. I have polished it and I have given a new crown, replaced this crown. So as I said, he didn't want too much of staining on this side, and his teeth did not have as many intrinsic stains on this side as he had on his right side. So what we did was we gave him slightly brighter teeth and a little higher value. We matched it to the canine, okay, rather than match it to his posteriors because he wanted slightly whiter and brighter teeth. Now there was a buccal undercut over here, and what I did was I removed this undercut. In fact, that's very obvious in previous slides. I'll just quickly go back and I'll show you. I forgot to discuss that in the, I think it was this slide. Yeah, here. So you can clearly see this over here, this undercut over here. Okay, there is mild abrasion, probably due to brushing over here. Now, it was very mild. It did not warrant any restoration over there. I didn't want to restore anything. So what I did was I removed that undercut and I really smoothened and polished it. And you can see the difference in the marginal gingiva over here. Okay, there is no undercut over there now, and it's been smoothened and polished, and the gingiva is adapted very beautifully. These are all CAD-CAM PFM crowns with equigingival margins, and you can see how beautifully the gingiva is adapted. It's not short or anything anywhere. This is a comparison, pre-op and post-op on the left. You can see how we have restored the curve of SPE and how I have managed to raise the VD also. Now, why is there no contact on the buccal of 3-4? Can you see this? There's no contact over here. Why? Actually, the reason for that is because if I had to get contact between 3-4 and the upper on the buccal, I would have to give an overlay or add composite or do something over here. But the second I do that, you know what's going to happen? The occlusal level, the occlusal table of 3-4 will become far higher than that of 3-3, 3-5, and 3-6. And that would make my entire curve of SPE go for a toss. So, a little bit of compromise. We did not give a contact on the buccal, but there is contact on the lingual. There is lingual contact. It's just that there is no contact on the buccal. So one has to see the case overall sometimes. See, when you're doing selective FMR, you're not involving all the teeth, then you do need to make these few subtle changes, which are a departure from the norm, and that's okay. There's nothing wrong. Now, the mesial lip of composite that I had created is now removed. It's removed. The minute that these crowns were fabricated and the patient was given these crowns in occlusion, in this very same appointment, I cut all that composite off. Okay. And it's just like any other notcher now. Now, meanwhile, what happened was, by the time the FMR was finished, see, when I started the case out and I built up all those composites, I did tell the patient that, let's see how it goes. If your composites last, fine, use them while it lasts. But if there is going to be repeated fracture of any of the composites, we are going to have to convert that into an onlay or into an overlay for you. Because there's no point in constantly doing the same thing and expecting different results. We're not going to get it. Now, very surprisingly, all the composites lasted except for the composite on this one particular tooth. This particular tooth, I think I must have repaired it at least 5 times in the course of the entire treatment. So it was very obvious that this particular premolar was taking a brunt of the masticatory stress, which the composite cannot withstand. Okay, it needed an indirect. Now, the patient had very severe sensitivity. I mean, so severe that, even scaling took a lot of time. It had to be done on perio mode with limited vibration and with a lot of local anesthetic spray. So I really did not want to take the risk of prepping this vital tooth for a crown, because I was afraid, what if the patient developed, irreversible sensitivity and it ended up going in for an RC, and I really didn't want to do that. So I prepped the tooth for an onlay, and he had very severe sensitivity even for this amount of prep, despite using desensitizers, despite on chair side, despite putting the patient on desensitizing toothpaste, despite everything. Such was the level of sensitivity. Okay, we fabricated the onlay patient. This is the onlay prep, 360-degree onlay prep on the cast. And this is the final occlusion with the onlay. We got a nice shade match and everything. But, sometimes things go wrong in cases. Okay, you cannot predict everything from start to finish, and some things are not in your hand. The patient went on a vacation, and the patient ate something very hard because the food there was such, the rotis were like really, really hard. The patient told me this later. So when the patient ate something very hard, what happened was this crown popped off, which is a no-brainer because, this tooth had the least abutment height. And when this tooth popped off, the onlay over here also popped off. Okay. Even though the patient's excursion was beyond the margin of the onlay. When I had fabricated the onlay, I had kept all of that in mind. I did not fabricate the boundary of the onlay to coincide with the patient's lateral excursion. And by the way, we gave the patient group function. Okay. In this case, not comfortable with giving canine guidance, especially when, the canines have been built up with composite. So the patient's excursion did not coincide with the boundary of the onlay, but yet the onlay popped off and the patient swallowed it. The patient brought the crown back, but not the onlay. So what happened? We had to refabricate a prosthesis for the patient. Now, when I had to refabricate the prosthesis for the patient, it didn't make sense for me to fabricate an onlay one more time, because if it's happened once, it can happen again, right? There is no guarantee or warranty or anything that's going to apply from the lab when the prosthesis itself is gone. Okay, we have to make a new one. So this time I converted that tooth into a crown, and we have now crowned it over here in this pic. It's now crowned. It was very difficult to do the crown prep for that patient. Very, very, very difficult. Severe sensitivity, vital tooth, and I'm happy to say that the tooth remained vital right till the end, right till now. There was no issue. We managed it somehow, and we gave the patient a crown. So this is the final mutually protective occlusion that I have given the patient. As I said, I did not plan to give the patient a typical anterior edge-to-edge bite in NPO. I terminated it a little short of that, and just where the wear pattern is beginning, it stops there. It doesn't go beyond that. This is where the wear pattern was beginning, and I terminated it over there. So you can see that the disocclusion is not that much. It is there. It's there, but it's a little minimum. This is the lateral excursion of the patient. So we got a very good group function on the right side, okay? We have plenty of contacts. In fact, we have contacts right from the molar till the canine. But on the left side, not so much, because see, we were doing We were doing selective FMRs. We were not including all teeth. And I mentioned that there is no buccal contact over here. And I also explained the reason why there is no buccal contact over here. So as such, we got one contact here, we got another contact here, and we got a contact here. So we had 3 contacts. We didn't have 4. As I said, ideally you should have 4, but minimum you should have 3. But we got 3 contacts, and that's fine, okay? Because if I wanted an ideal contact of 4, I would have needed to overlay this. I would have, and even if I overlaid this, I could not have done much about this if I wanted to maintain the plane of occlusion. And I didn't want to touch that tooth just to get that measly contact over here. But that's okay. 3 is not bad. 3 is okay. Stand up with 3. Now I'll recall the patient after 6 months. So this is the occlusion in MIP. It looks more or less the same as what I had sent the patient with. There isn't much difference. The gingival health is very nice. Everything is fine. But sometimes patients surprise you. The bite surprises you. The occlusion surprises you. And that's the reason, they say the mouth is the best articulator, because check this out. We now have improved contacts in group function on the patient's left side, which happened all on its own. There was no intervention from my end. The patient's occlusion settled down on its own and developed all these multiple contacts on the patient's left to match the patient's right. So occlusion can change. Your excursive occlusions can change over a period of time. And sometimes the change is for the better. You get better results. So, there is nothing wrong with going slow, with doing the minimum, with having a wait and watch approach, because patients surprise you like this. And that's why I said at the beginning, I had no idea if I was going to achieve, if I was going to achieve a good occlusion, if I could terminate the case well. But when I saw this, it had exceeded all my expectations. And I really could not have been happier, because this particular thing really did exceed my expectations. I did not expect this at all. So people and patients surprise you. And if you want to have this kind of a rapport with your patients, okay, you need to keep multiple things in mind. Patients want minimum treatment. They want minimum appointments. They want minimum, a minimum bill to be handed over to them. And that's not always possible. I know that, because as we say, in Sasta, Sundar and Tukau, we can never have all 3 together at the same time. You can have only any 2 at any given time. But with selective FMRs, okay, you can come to a mid ground between the 2 extremes. I've said this in all my other webinars also. What does the patient want versus what do we want as a clinician? So what we want is always an ideal treatment plan, and what the patient wants is always a compromised treatment plan. And sometimes we need to come to a little bit of mid ground. And, patients do understand, not all, but some. They do appreciate, they do understand the efforts that you are taking to come to that mid ground. And, these type of selective cases are actually very, very difficult for the technician also to do. Trust me, the technicians love the typical FMRs, where 28 teeth have been prepped and they just need to raise the BD for all 28 teeth and just crown all of them and give the crowns to the dentist. Those are the easiest FMRs, both for the clinician as well as for the technician. These kind of FMRs are actually very, very difficult even for the technician. So, not all technicians are interested or willing to break their head over such cases. That's another thing, I'll be honest. There are certain technicians who straight away tell you, or who've told me, ma'am, nahi hoga. They stop picking up your calls, or they'll give the case to another technician, and all that stuff. So you need to have a good lab, and you need to have a good tech, okay, who you can work with. So now all my cases are done by the same tech. Okay, so till that tech is there in the lab, he's going to do all my cases. I don't believe in going and giving my cases to different people, because it takes very long for the technician also to understand my way of working. So this particular tech of mine has done almost all my cases. in the last, I don't know, 2 years now. Okay, and he knows my working style, he knows my expectation, and they understand my mindset. So even if I explain occlusion to him, he gets it to some extent. He understands. So that's another very important aspect. I cannot do it without having a good partner in the lab. And I hope you all enjoyed this webinar. And I know it's a tough case and it's a tough webinar, and some of you may have a lot of questions. Feel free to ask. Some of you may not have questions now. They may come in your mind later. So you all can ask me anytime. Feel free to connect with me. This is my Insta handle. This is my Facebook page. This is my Facebook profile. And I'm always ready to connect and sort out your doubts and your queries. And there will be a recording available of this webinar for a limited period of 7 days. So in case any one of y'all want to go back and rewatch, maybe not the entire webinar, but you may want to watch certain, very, very selected, areas of the webinar. Maybe you had a doubt, or maybe you didn't understand. You can do that. So, Dr. Urvashi, are there any questions?
Yeah. Ma'am, can you switch on your video so
Yeah,
I can see you while I talk to you?
Yeah. Am I visible? Yeah, I'm visible, right?
Yeah. So thank you so much, Dr. Deepa, for that enlightening session. So starting from the different types of FMR that we have, we learned how to assess the different types of wear that is available. We discussed whether composites work for an FMR or not. We discussed the complete workflow of selective FMR in great detail, and it was truly a roller coaster ride. To understand the concepts of selective FMR the way you explained it, and then discuss the case side by side, truly enhances our learning process, as we can see how the concepts are applied while they're being explained to us. So thank you so much for that, Dr. Deepa. And I have a question for you. Could
Yeah.
you please define an onlay and an overlay, maybe according to the GPT definition, or how it is being defined currently, or whether overlay even exists as a GPT definition term or not?
You know what? No. See, I tell you what. These overlays, or V onlays, all these are new things. Okay. There is no GPT definition for all of this. All of this are new concepts, and they're based on adhesive dentistry. Because as I mentioned, see, when I did my postgrad, okay, I learned FMR in the very typical manner, which is prep all 28 teeth, crown and bridge all 28 teeth, raise the VD, and that's that. And at that time, as a student, even that was very tough. Okay, it's not easy. Even that was very, very difficult for us as students. But as a clinician, over a period of time, see, when I did my PG, we didn't have Facebook, we didn't have all these groups, we didn't have Indo Heavily, we didn't have all these groups, so we didn't have the mode of learning that we have today, where different clinicians come and share all their cases, and you learn so much just by looking at someone else's case. And obviously, the concepts of webinars also did not exist back then. So if you're in touch and you start looking at other people's cases, and when you start seeing what people are doing out there, you realize, okay, when adhesive dentistry came in, that you don't need to do full crowns. You will get good adhesion and good retention even without full crown. So that was the whole premise of where an overlay or a V onlay came from. So what is a V onlay? A veneer plus an onlay on the buccal surface of posterior teeth. Okay, it can also include the palatal surface depending on the case. Like if you want to raise the bite, in that case, you give a veneer and you give a onlay, which includes both the buccal and the palatal surface of that posterior tooth. Usually done in premolars. You do not do this in molars. This is only for premolars. Okay. Now, as I said, newer materials are available today. We have GSEM for zirconia. So I use GSEM, and I do a lot of zirconia. I prefer to do more of zirconia than lithium disilicate. Like even for this case, if I gave the patient zirconia, I didn't go and give the patient lithium disilicate. And GSEM comes with its own primer, which is specific for zirconia.
But my question
is, I'll come to it. I know what your question
and where you give them,
right?
Specific locations.
I will. But again, the material also matters. Why am I discussing all this? Because where you give what also depends on the material you're using, na? That's the reason I'm discussing this. See, there are cases where the patient's bite is heavy, but you want to do you do not want to give a full crown. You want to be selective. Okay. There are cases where the patient's occlusion is terrible. The patient could have an edge-to-edge bite or a class 3 occlusion. So I give an overlay in such cases with zirconia. You do not make zirconia onlays because the retention is poor. If you make an onlay, it is only in lithium disilicate. So what you give where depends on the occlusion that you have in the patient's mouth. So if I have, and most of my cases I have terrible bites. Most of my cases. Terrible means terrible. They're either bruxers or they have a class 3 bite, or some of them have bites, where literally in the posterior, it is the cuspal tips which are contacting with each other. So I will not give lithium disilicate there. So if my choice of material is zirconia, I have to give an overlay. So what is an overlay? An overlay, there is no GPT definition. I'm not going to give any GPT definition for only either. I'm going to go based on what we say clinically. What we do is take a pencil, okay? Ask the patient to glide his jaw in excursive on the same side as the tooth that you're prepping. You will easily see the excursive pathway limit where the upper cusp is touching the buccal surface of the lower. Please mark a line over there. Usually, this terminates somewhere between the occlusal third and the middle third in most patients, okay, on an average. An overlay is something that you do which extends below this line, but it is above the gingival margin. Do you get me?
Yes.
An onlay is something that you do above this line.
Okay. So onlay and overlay, the difference has nothing to do with the coverage of cusps you're saying, but it has to do with the extent of the margin of the restoration.
Yes.
Okay.
It's got nothing to do with cuspal coverage. So therefore, the definition doesn't even apply over here. And most clinicians in their clinical practice, they want clinical knowledge of how to judge a case. Honestly, people, we don't remember definitions when we are practicing. So whether you decide to give an onlay or an overlay depends on the patient's occlusion. Okay? If the patient's occlusion is a good occlusion, it's class 1, no bruxism, no nothing, and the patient's, if the patient has a canine guidance, you can easily give an onlay. There is no question of contact between the onlay and the opposing tooth, right? So the onlay is not going to dislodge because the margin of the onlay is never going to come in contact with the cuspal tips of the opposing tooth. If the patient is having canine guidance, which is what you see in a dentate individual. Okay. But in these type of cases, in FMR cases, the patient, we give them group function. We mostly give them group function because the canines are attrided and we cannot allow the canines to now bear the brunt of the masticatory stresses in lateral excursion. We now want that load to be shared by all the posterior teeth. So that can only be done in group function. So when you are doing it in group function, then it's always better to give an overlay, and it's always better. See, this is an individual choice. I know clinicians who give overlays in lithium disilicate too. And I'm not saying it's wrong. It's not wrong. It really depends on every clinician. So I prefer zirconia. Someone else prefers lithium disilicate, and that's okay. As long as the occlusion is correct and the clinician is confident, it's fine. It's fine. But in a group function, it wouldn't make sense to give an onlay because it's definitely probably going to, interfere, the margin of the onlay, every time the tooth slides back and forth in the excursion, it's probably going to rub on the margin of the onlay. And there is a chance that the onlay will dislodge. See, if your occlusion is correct, it will dislodge. If your occlusion is wrong, it will fracture. So knowing all of this, why did I go and give an onlay in this patient? For what? Why did I go and do that? Because the patient had terrible sensitivity and I was afraid of prepping the tooth for an overlay or for a crown. I was really afraid. I was afraid that the patient's sensitivity would be so irreversible that we would end up having to do RC. And see, these type of aged patients, okay, the root canal is, we were in lockdown. I'm not an endodontist. I do root canals, but then my expertise is limited and I have no shame in admitting that. And the canals are often calcified and whatnot. And I'm not going to get any consulting endodontist in the middle of the lockdown to come to me and, do my patient for me. So it made sense at that point in time to just minimize headaches. So that was the reason that I ended up just doing an onlay for that patient. And then when the onlay dislodged and we were redoing it for the second time and the patient was paying once again for the lab charges, and also the vertical height of the tooth was less. See, because that happens, okay, in such cases. One more thing we need to keep in mind. Sometimes what I do is, if the vertical, there are cases where the vertical dimension is less for that particular patient. Okay, the VD of the VD is less, and therefore the crown height of the tooth is less. So when you try to give an overlay to the patient, there would hardly be 0.1 or 0.2 mm, between your gingival margin and between your margin of the overlay, and it then doesn't make sense, just leaving that 0.1, 0.2 mm of tooth structure. So sometimes what I do is I modify the overlay also. Basically, I do a morphologically driven prep. So on the buccal surface, or the surface where the height is less, I end up taking the prep down, till the gingiva. Because sometimes what happens in certain teeth, you have good height on one axial wall, but you don't have good height on the other axial wall. So it could happen that the patient has good height on buccal, but not so good height on the lingual, because that's the wear pattern for that particular patient. So I give an overlay margin on the buccal, but then on the lingual, I go all the way till the gingival margin. So I give a margin which is of an overlay prep on the buccal and on the mesial and distal axial walls, but on the lingual, I take it down till the gingiva. And that's fine. That's okay.
So basically, what I can understand is that you're saying that the preference of zirconia and lithium disilicate is usually based on the clinician, but it is actually the occlusion that is
Yes.
supposed to be the driving factor for choosing between these two preps.
Yes.
These two materials,
Yes.
basically. But I also wanted to point out that what if isn't the dental substrate an important choice as well in choosing the material, because we know that lithium disilicate actually bonds to the tooth, and whereas zirconia cannot offer that kind of bonding as of now.
Yes,
So do
I
you
admit
think
that.
that should be a matter of
No, I completely admit it.
choice as well?
No, I do not deny that. I do not deny that. As I said in the beginning itself, you cannot expect a bond of zirconia with enamel, or with enamel the way you can with lithium disilicate. That's something I said in the beginning itself. You cannot expect the same. Okay, but at the same time, okay, you cannot compare the fracture resistance of lithium disilicate with zirconia. There is a difference. So you can't have it all. You have to compromise somewhere. So either you get very good adhesive bonding, but then you got to take that risk if it fractures or whatever. Or you go for zirconia and you may not have the same adhesive bonding that you have with lithium disilicate. But if it comes out, you can always put it back. Okay.
Agreed.
Yeah,
So a lot of factors basically go into choosing occlusion, the type
Yeah.
of substrate, bonding.
Yes, because see, re-cementing or rebonding an overlay is a 15-minute job chairside. It's going to cost us nothing much as compared to a lithium disilicate only fracturing. And then see, it becomes very difficult. See, let's keep one thing in mind. A lot of labs do not offer warranty for lithium disilicate. This is a fact. Whether you do an onlay or whether you do a veneer, a lot of labs do not give a warranty. So now, if it fractures, who's going to foot the bill? Is it us as the clinician who's going to foot the bill again? Or are we going to recharge the patient one more time? Because if it fractures, it's because of the wrong bite, wrong occlusion, wrong choice of material. So are we correct in penalizing the patient for that? But then at the same time, it pinches our wallet. See, let's be honest. If we have to, and the lab charges are very high. It's not 300, 400 bucks. It's quite high. It's 2.5, right? Minimum. So it pinches our wallet too. You're not earning anything, but now you've gone at a loss. So now to avoid all these chairside headaches is the reason why. See, it comes to some extent, it's also patient management also. It's occlusion and patient management also that you take into account sometimes. So zirconia, at least if it dislodges, like there was that case, the smile rehab case, where I said the case itself was like that one particular crown was constantly dislodging. The bite was correct. I could not have corrected the bite beyond that. It was not possible. The case was like that. Okay. and the patient also was not following instructions. So the crown kept dislodging, and that's fine, because if it dislodges, the patient is going to bring it back, and I'm just going to re-cement it back.
Yeah.
But if it fractures, it's a whole different story.
Agreed.
So these are when you
Small
have
things that matter.
yes.
Yeah.
See, when you have high ticket cases in your practice, okay, you should really try to minimize friction points with the patient. Because however nice the patient may be in the beginning, a lot of seasoned practitioners will agree to this. They start out very nice, but by the time you come to the end, and by the time you realize what a hefty bill, they have been offered, and it doesn't matter how much you've tried to save their money with composites, or by doing selective FMR, and by not involving all the teeth, and how much their bill would have been in a 28 tooth FMR as compared to now. It doesn't matter. They sulk and they grumble and they moan, and they feel we've looted them. In short, because this is something we keep reading on social media, which patients write about dentists. This one looted me, that one looted me. These are the exact words that patients use about us. So, FMR cases, or any high ticket case for that matter, and I do a lot of high ticket cases in my practice, just minimize friction. And finances is a very sore point with patients. Very sore point. So I would rather compromise on my adhesion with zirconia not being at the level of lithium disilicate, rather than to take the risk of the fracture and then wondering who's going to foot the bill. But that being said, as I said, there are newer materials. Okay, fine, it cannot be compared with lithium disilicate or Emax. It cannot be compared, but at the same time, it's not as bad as GIC either. It's not as bad as just looting the crown with GIC. The way PFMs used to be looted in the past, when you mix GIC and you loot it. It's not as bad. GSEM is very good. It's a dual cure resin cement, and it's excellent. And I'll be very honest, till today I have never had any debonding of any of my zirconia with GSEM. Not a single one. Not a single one till today. And I also use a primer by Shofu. There is a Shofu alumina zirconia primer that you get, which I coat on the the inner surface of the crown. It's a no-brainer that if we are trying the crown in the patient's mouth, there will be all sorts of
Salivary deposits.
Yes. So you have to remove that. Sodium hypochlorite is the cheapest option to remove that, which is there in every clinic. If you want something more fancy, then you have to invest in Ivoclean. One out of these two. First, that has to be done. If you have a chair side blaster, you can blast the inner surface of the crown. I get mine done from the lab itself. I tell them to just slightly microblast it and give it to me. Okay? Then I use this Shofu primer. I use the GSEM primer on the tooth, and then I use GSEM. I've never had.
We are.
Yeah. I'm almost done, Dr. Aksar. I have never had a debonding. I've never had a debonding except for that one case. That one case, and that case was like that my smile design case. So does that answer your question, Dr. Urvashi?
Yes, definitely it answers, more than answers the question, because we've gone and digressed into other aspects of cementation as well. So I would just like to thank you for all the expertise and the knowledge that you have imparted to us on a sunny Sunday morning. So with the closing of another amazing session, I would like to thank our sponsor, Group Pharmaceuticals, for helping us conduct this webinar. And we will all see you again sooner than later with the next session of our series. And don't forget to register for that one. Till then, happy reading, signing off.
Just one.
Yes,
one,
ma'am.
Yeah, I have a private question actually from one of the participants, which I saw only now. Dr.
Okay.
Tushar, while doing FMR cases, single crowns is good or joint crowns are preferable? See, again, I'll just answer it in brief. And Dr. Tushar, if you can connect with me on social media, if you don't understand, please do so, because we are really short of time now. If your abutment height is good, you can go for single crowns. The concept of joint crowns was utilized when 28 teeth were being prepped. So it is difficult to fabricate 28 crowns with proper interdental margins and then to loot 28 crowns. So they used to make three units, three anteriors, three posteriors together, or four posteriors together. That's how it used to be done. But in today's concept, if you're doing a selective FMR and you're doing very few teeth, you can very much go in for individual crowns. And for all the prosthodontists who are there with us today, happy prosthodontist day.
Happy Prosthodontist Day, ma'am.
Thank you. Okay, so yeah.
All right, I think we can close the session.
Yes. Thank you, everybody. Thank you so much.